You are watching the Doctalk Show.
You are watching the Doctalk Show, and we are talking about the urinary bladder and bladder-related conditions. We have seen a number of conditions and how to investigate them and come up with a diagnosis and how to manage some of them. But right now, Dr. Frank, tell us about cancer. We know cancer is one of our biggest issues here, and like we've seen, you've said cancer of the bladder is also there, like many other cancers, and does happen in a certain risk group that gets the cancers. It is higher than in other people. But once the person has been diagnosed with cancer, then what?
Unfortunately, it's one of those diseases which also present a bit late. But suffice to say that any hematuria, any bleeding in urine should not be overlooked. It must be investigated and we confirm that there is no bladder cancer. So in fact, we say hematuria is bladder cancer until proved otherwise. So once we diagnose cancer of the bladder, we must stage it by doing several things. Of course, we look in with a scope, take a tissue, and send it for histology. But while we're in, we're able to tell the size
of the bladder,
of the tumor in the bladder,
okay,
and the location, and how many they are. All those are very important. One lesion is different from multiple lesions. Okay. A raised lesion is different from a flat lesion. You know, a 2 millimeter lesion is different from a 5 centimeter lesion. So that must all be documented. Of course, you must have done some investigations, ultrasound, CT scan. In the CT scan, you want to look at the lymph nodes. Has it spread? We can pose that. So suffice to say that must be staged.
Okay. And once you have now staged.
Yes. There are also, without getting too much into the academia, let's just talk of 2 or 3 groups. The first group, we call it a non-muscle invasive, non-metastatic cancer. It means, like we said, the bladder has got a lining on the inside, which is called the mucosa, that pink one, and then it has got muscles, okay, and then has got the outside. So when we say non-muscle invasive, it means it is within the inner lining, but has not yet reached the muscles. So if it's within the inside lining, has not yet reached the muscles, and has also not spread anywhere else, that is the first category, and that is potentially curable by operating it. We call it endoscopic control. You can go in with our gadgets and cut it, finish it, put medicine, and follow up for about 2 years. Potentially curable.
Okay.
If it has reached the muscles, we call that muscle invasive, and it is non-metastatic. It means it has reached the muscles, but has not spread
to other organs.
To other organs, bone, lungs first, lymph nodes, and all that. Again, that is muscle invasive, non-metastatic. The solution is to remove the whole bladder. We call it radical cystectomy. Okay. So you cut out the whole bladder. If it's a man, you remove the prostate as well, remove the seminal vesicles, you remove so many things. It is even more radical than radical prostatectomy. And that one is potentially curable. Of course, once you do that, then you must find a way to deal with the urine.
Yes, that's the subject. My question now.
So
we have nowhere to store the urine, so that's the subject for another day. But we have now removed the whole bladder.
And we do urinary diversion.
Okay.
So that's another procedure. So it's a huge one.
So you divert the urine?
We divert the urine.
It doesn't come and pour in the pelvis and just stay there?
We divert it. So it's a huge procedure, and again, you must only undertake it if there are benefits. If you are sure it has not reached elsewhere, and because it will be sad for you to do this very radical surgery, divert the urine, and lo and behold, the cancer wakes up in another part of the body. So you must be sure that we don't have it to have spread anywhere else. Okay. And then that's potentially curable. But if it is any of the above, whether muscle invasive or non-muscle invasive, but metastatic, if it has spread to anything,
it has crossed beyond the bladder.
Beyond the bladder. And believe you me, it can just be a little lesion here, but has already crossed, because cancer has spread through the blood, through the lymph, and also locally through the next organs. So it could have spread from the blood and it's already in the lungs, or it's already in the lymph nodes. then our mainstay, and remember our mainstay of treatment is chemotherapy. So we don't touch the bladder, we don't do anything about it, we now give chemotherapy. Now, in these other ones, the non-muscle invasive, non-metastatic, or muscle invasive, non-metastatic, there is also a role for chemotherapy, but it's not the mainstay of treatment.
Okay.
Okay. So if it is metastatic, there the mainstay of treatment is chemotherapy. You could do some surgery of the bladder to reduce the bleeding, to reduce the pain. So you go in and just burn it and stop the bleeding.
Tumor.
But you're not doing it to cure it.
Okay.
And all this needs to have been explained to the patient so that they set the expectation, but also for you, the surgeon, to know what your aims are. What are you trying to achieve? Are you palliating? Are you curing? For my colleagues in the medical world and for my patient, you must tell your patient, are you going to cure it? And it is okay to tell the patient that we cannot cure you. You can tell it to them in a nice way because you're not God and you're not the one who brought the cancer. So you tell them the stage at which it is not curable. However, there is a lot we can do to keep it under check.
But then is there a role for radiotherapy?
Yes.
In cancer of the bladder?
Yes. So even with the curative options or the palliative option, you can play between chemotherapy and radiotherapy. Now, those details you leave the oncologist
to deal with them.
To deal with. But there are all those options. There's surgery, radiotherapy, chemotherapy. And there are various chemotherapeutic regimens. You give this, you give the other. But that is medical jargon.
So as we wind up, we want to give you some ray of hope. We can prevent diseases of the bladder. So, Dr. Frank, we mentioned people who are at highest risk of getting conditions of the bladder. Yes. What can they do? I work in a factory, that's the job I have, or I'm a farmer, I'm a rice farmer for so many years. What can I do now to prevent all this? And also not to progress to cancer, because some have already gotten these infections, but have not yet progressed to cancer.
So, if we can begin with the infections, we get prone to infections. The issue is early diagnosis and effective treatment to prevent recurrent ones. For our honeymooners, take it easy, wash up. You can do 10 rounds or 300 rounds, but wash up. If you have gotten in one entrance and you come out first, wash up before you get into another one. Don't over-inoculate and contaminate.
Okay, don't mix entrances. So in short, we are saying don't come from anal to vaginal, then to oral sex, back to vaginal. You're spreading different...
You can do it whichever way you want, but clean in between.
Okay.
Okay. For the ladies, of course, you are at high risk during your menstrual periods, during pregnancy. So stay extra clean, wipe front to back. But ultimately, across the board, drink a lot of water. Don't hold urine back for long. And if you have any bit of symptoms, run to a doctor, early diagnosis, effective treatment. Make sure your doctor is talking to you. We are in an information age. Do some Googling, but make sure the doctor is answering your questions. If they are shy, if they are timid, if they're ignorant, look for specialists. And we're there. Currently, Uganda is producing over 100 specialists in a year. The universities are producing specialists, and they also know how. The good thing with the specialists, they know their limits, and they respect them. Now, the ones who are a little younger and have not specialized, they like to meddle in other areas. So look for a specialist who can direct the right person. For cancer, for the factory workers, you just need protection. And there are usually these protections, either masks for the painters, make sure you mask up, make sure you glove up. This issue of looking like you have come from your paint tin itself, paint all over yourself. You're trying to threaten people that you're working very hard. No, it's not helping.
You're exposing yourself to cancer. Including
your off-row. If you're a painter, it doesn't have to be so full of paint. That paint from your overall makes contact with your skin and you contaminate yourself. So change your overall, wash them up, and make sure that you are protected. Farmers, put on gumboots. If you're going to spray your crops, mask up. Make sure that the chemical, whether the fertilizer or the pesticide, does not get in contact with you. Of course, it cannot not get in contact with you, but you minimize. My brothers who spray cows, don't act like a ninja. Put on a mask, put on an overall, and go and wash up.
After.
As soon as you finish, you go and wash up. That dilution, that wash up, minimizes the risk.
Okay, thank you very much. And for like any other cancer, we've said it over and over and over again. Stop smoking. Stop the use of tobacco, any tobacco product. Shisha is now a lifestyle in Kampala. A lifestyle, if you smoke shisha, you're in a different world altogether. You think you're a slay queen, but you're predisposing yourself to cancer, and you'll actually die younger than you're supposed to die. Drinking alcohol, please minimize your alcohol drinking. Must you drink alcohol? If you must, please have low levels of alcohol or completely stop drinking alcohol. Diet, please eat healthy diets. We have vegetables. We are a country that is very well endowed with food. Please eat local foods. Eat food that grows on the ground or in trees. Do not eat processed foods. There's no reason why we should be buying processed foods as Ugandans, because we have more than enough markets. Much as like we have been told pesticides, and recently I saw tomatoes are full of pesticides and all these crops. We can do something better than people who are out there and are unable to access unprocessed foods. Physical exercise. Right now I saw the government has started an exercise. The exercising once in a month or once in a quarter does not equal to exercise. But at least it's something, but it won't prevent you from cancer. Start being physically active. Get out of your chair, get out of that car and start walking, and you'll prevent so many cancers. You'll reduce your risk of cancer. If you're obese, you must lose weight by all means. Healthy eating and exercising will help you lose weight. So thank you very much, Dr. Simwe. Once again, it has been a pleasure having you in studio to talk about issues that affect the urinary system. As a urologist, there are many specialists out there. If people do not know urologists, there are people called urologists. They've been trained to deal with anything that comes to your urinary problem or genital problems for men. And I remain yours, Dr. Fiona Atuhebwe, the sexologist. I do different things from Dr. Frank because mine are sex-related problems. He does urine-related problems and genitalia in men. Sickness is not sex-related problems. So remember to follow us on our social media platforms, on Twitter and on Facebook, and also to subscribe to our YouTube channel. See you next time on the Doctalk Show.